If you work in public health and don't have a degree in public health, this is the episode for you. In this episode, I feature Dr. Ross Brownson, Distinguished Professor of Public Health at Washington University in St. Louis, to give you a 30-minute crash course on evidence-based public health. So get ready. You might even want to take some notes. We'll go over what evidence-based public health is, what we can call evidence, why intentions and perseverance are truly not enough when it comes to doing good for the planet and the underserved, things that can go wrong in this practice, and how we can begin to incorporate some of the strategies as public health workers today. For more information about Dr. Brownson, click the link in the description for his full bio. I hope you have your notebooks out. My name is Hetal Daman, and this is the Global Health Pursuit. Ross, thank you so much for being on the podcast. I think this is a really important topic for people who are interested in global public health, not just in academia, but also in practice. So just first off, Ross, tell me a little bit about yourself and what you do.
Sure. Yeah. So I'm a professor at Washington University in St. Louis. So the main part of my day job is obviously teaching students. And then I do a lot of research in an area we call implementation science, which basically means we know a lot about what would make people healthier or help them to be healthier. We invest in that, but we don't always connect it up with the organizations that could deliver that. And so implementation science tries to connect the science with community practice and organizational change and policy change to improve health. And my background is in epidemiology, and I spent the first 8 years of my career working in a state health department. So a lot of the work I do is shaped by what goes on in a state public health agency, and then working with local partners, which is, state and local public health is how most public health services are delivered in the United States.
Right. So you teach a evidence-based public health course at Washington University. And it's very interesting because, I spoke with your wife and she was telling me that, this course is 1 week. Or it could be, there's a 1 week course and then there's multiple lengths of courses, right? But it's essentially like a crash course on evidence-based public health. And it's for anybody who's interested in working in the public health space to understand a little bit more about how to help people, in a better way. Who is this public health course really targeted towards?
Yeah, so as a backdrop, one of the things people may not know about public health, there are several 100,000 what we would call public health workers in the United States, and that's mostly governmental public health, state and local public health. The vast majority of those individuals do not have any formal training in public health. So that's a real challenge because they come from all different disciplines. It's sort of it's a mosaic of people where you might get someone with a research background or a English background or a community organizing background. But there's a core set of skills that we would like people to have in public health. And so the point of the course, and it started about 20 years ago, was there's a vast need for on-the-job training for people working in public health who don't have any formal training in a public health discipline like environmental health or policy change or epidemiology. And so it's meant for what we call sort of mid-level public health practitioners. So that might be, let's say someone is running the immunization program for the state of California. That would be the kind of person, especially if that person doesn't have the formal training in public health. And it's funny because we started the course thinking, we'll train a bunch of people and then we'll be good to go and we can sort of retire the course. But there's a lot of turnover, and the turnover has gotten even more so over the last 3 years during COVID. And so there's basically a limitless need for this kind of on-the-job training in a short format. I always sort of joke it's like getting your master of public health in a week. There's a lot we cover in a short period of time, but it's a great experience. I think we just did a course several weeks ago, and the students are terrific, and we always learn a lot from them because they're experiential learning. They're working in public health practice. They're the heart and soul of trying to keep this nation healthy.
I mean, question for you, when do people realize that they may need some training like this?
Yeah, it's a good question. I think that it's probably as soon as we talk sometimes about this idea of wicked problems, and that those are usually complex problems. They've usually been around for a while, and they have complex, difficult solutions. So probably when it really hits them is they face some kind of a wicked problem, like handgun violence in a city, or excess deaths from COVID, or increasing use of electronic cigarettes and vaping among youth, where they see something going on in their local community and they want to build their skills to be able to solve that in what we sometimes would call a wicked problem. That's probably where it hits. And then sometimes it's most of the public health in the United States is funded through the Centers for Disease Control and Prevention. And so if a practitioner is getting funding to do something, they may realize, oh, I've got this grant, I've got to do this now, and my team doesn't have all the skills to do it. And so we need to figure out how we pick up those skills while people are already on the job, because they can't stop and go back and get their public health degree. So they're doing it. It's sort of like, you're building the airplane while you're flying it. And that's sort of how public health is.
That is so true. And I think that it's interesting because I think a lot of people are so well-intentioned in terms of what they want to do to help, to serve the world. And then oftentimes their well-intentions are kind of, they face a wall. And there are books that I've read. One of them was Toxic Charity, just talking about intentions are not enough. You need to understand the community and gather evidence in order to create a better program to help sustain whatever you're doing. I think that leads me into my next question. So the slides that you had sent me around, I think this is like a slide deck that you teach, right? And one of the quotes on one of the slides said, public health workers deserve to get somewhere by design, not just by perseverance. That kind of sums up kind of what I said, it's like all intentions, but there's no design behind it. This was really profound for the work of public health workers. So I want you to talk about a little bit, what does this really mean? Like, what does design mean?
Yeah, that's a great question. That quote really resonated with me. It was in a journal article I read years ago. And public health workers enter for all the right reasons. They enter because they want to make a difference in society. They want to address health equity. They want to make the world a better, healthier, happier place that people live in. And that's where the perseverance comes by, but they don't always have the design. And so the design to me is sort of the roadmap. And that's what we try to teach in not only our evidence-based public health training, but in any of the trainings we do is you want to sort of see where you're going. A great example historically I was thinking about is actually smallpox. Smallpox for 100 years in the world killed 500 million people. And we developed surveillance systems about how to track smallpox. We understood where it was going on. We understand the transmission. And then, of course, the biggie was there was a vaccination for smallpox. And the world, largely developed countries funding it, but then the World Health Organization mobilized, and smallpox was effectively eradicated in 1980. And that's where you had the data showing there's an enormous public health problem here. And then the design, the roadmap was we need to have surveillance. We need to know what's going on. We need to understand who this is really affecting. We need to understand transmission and prevention. And then, of course, the scientific advance of vaccines has been enormous. And so I think there's an example on a very global scale that you could bring down to any local community problem where you start with quantifying the issue. That's usually through epidemiology. You think about setting some kind of a goal. What are we trying to achieve here? We think about what are the ways to achieve a goal. In the public health parlance, that would be what's the evidence-based practice or policy to address this? And then how do we implement and how do we evaluate? And so those are sort of like we have this thing we call the evidence-based public health wheel that you've seen. And that's what we're trying to do when we take people through this training. When
you say surveillance, what does that mean?
That means the systems of, it's usually disease oriented, but it could be risk factors. So that could be, a good example is cancer. Cancer is a reportable condition in the United States, so that every cancer case that's reported eventually gets into a cancer registry. So we've got that becomes surveillance data so that we can now track our rates of, so there's usually in the world I live in descriptive epidemiology, we talk about person, place, and time. Person is who's being affected. Place is what's the geographic distribution, U.S., globally, otherwise, and time is what's happening over time with a disease or risk factor. And surveillance is basically it's one of the foundational public health tools to be able to make change. That
makes sense. There was a slide that I saw in the deck that was really so funny. And it showed Alice in Wonderland. And she talks to the Cheshire Cat asking him which way she should go. And he goes, well, where do you want to go? And she's like, I don't know. And then so he says, well, then it doesn't really matter where you go, So that makes so much sense.
And that's the surveillance tool. So the surveillance tool is helping you tell where you want to go. So are lung cancer rates going up or down? Are rates of use of e-cigarettes going up or down? What's a target we should reach? And then backing up from that, what are the ways to reach that target? If you don't know where you want to go, then it's hard to know how to get there. And that's sort of the Alice in Wonderland story that always resonates.
I think that's an analogy for life too. Such a big analogy for life. So can you give some examples of where this could really go wrong?
Yeah. On the big picture, where it goes wrong is the biggest one, I think, overall, is we vastly under-resource and under-invest in prevention in the United States and in many countries around the world. So if you look at the billions of dollars we spend every year, actually trillions of dollars we spend every year on health, especially on healthcare, probably something like 5% of the trillions of dollars spent is spent on prevention. Most of the money we spend is on treatment of disease. And that, in some ways, is because there's industries involved in treatment. So there's people who make drugs, there's people who make, surgical instruments and other methods of treatment. But it's also that if you think about prevention, which is what public health is all about, when we're doing prevention or public health really well, it's invisible. So if someone's got lung cancer and they're going into the doctor, they know what the issue is and they know how to treat it many times. Whereas if you're trying to prevent something, if you do your job really well in public health, then events aren't happening. The people aren't getting sick, the risk factors are going down. So I think sometimes where it goes wrong is we underinvest and we don't tell the story well enough about the value of prevention and what it means for people's daily lives. And then I think the other thing where evidence-based practices sometimes don't work out the way they should is that we don't always have the data. We don't always have the systems in place. Or, if you think about what we talked about, surveillance data, it's not a real glamorous topic to think about. I'm going to try to get the state government to invest another $100,000 in a surveillance system because it's sort of the backbone of public health, but it isn't very glamorous. And so I think it's also selling public health as a profession, which in some ways during COVID has become easier and harder. People now know what a public health agency is. They know what an epidemiologist is a lot more than they did 3+ years ago before COVID hit. But it also has created a lot of stress on the public health system. If you think like the mental health challenges that have come out through COVID, those have been not only for the population, but the mental health of workers in public health and in clinical care. And the turnover has gone up. There's the COVID politicized. I think the other challenge with all this is how politicized that public health can get. I've had colleagues who are running local health departments and have had their families threatened and have had to quit their jobs because of how political things like masking or vaccinations have become. And, that's not good for our country. That's not good for our communities.
Yeah, that just makes me think, in terms of prevention, you can almost like boil it down to eat healthy, exercise, and keep social with people.
Yeah.
Don't smoke. But
follow preventive care, like get your vaccinations and do early detection for cancer, like, mammography and colon cancer screening. And the actual practices we know very well, that's where that implementation science comes in. It's getting people to do them. And there's a quote that came out of the Canadian work years ago that said we need to make the healthy choice the easy choice. And what we've done too often in society is that we've made it difficult for people to be healthy. And people want to be healthy. If you ask people like their top 5 priorities in life, health is always in the top 5. But we don't always make it easy for people to be healthy, especially people living in disadvantaged circumstances, living in communities where resources are much more limited. And so we have to do a lot better job of addressing the things we know work and applying them more equally across all settings and all parts of the world.
I mean, this is something that, when you were talking, I just thought, when you said that it's hard for people to, like, society is actually making it harder for people to be healthy, it almost makes me think of the high prices of, like, in grocery stores, and things like that. Yeah. And I mean, the other day I went to the grocery store and I literally bought only, like, produce and meats. And they say, if you're at the perimeter of the store, that's like where the healthiest things are. And then I get up to the counter and it's like, what? Like, and they say, oh yeah, it's like $100 for 1 week for 2 people. And I can only imagine people who are already in a tough situation and they need to keep their children healthy. It's almost easier for them to just go and, go grab some Chick-fil-A, and I don't know. That's a different conversation altogether.
Yeah, it's very important though. And I think the concept you hit on is access, and access can be physical access. So if you live in certain communities, you could live in a food desert where even if you want to go to a grocery store and get healthy foods, it's very difficult to do that. And let's say you don't have a car and you have to take 3 different buses to get to a grocery store. So that's sort of the physical access. But then what you're all talking about economic access, that even when you get to the store are the healthiest foods, the cheapest foods. And too often they're not. So I think those are kind of that's exactly the kind of making the healthy choice, the easy choice, sort of an example. And you could think of any of the risk factors you mentioned about getting physical activity or not smoking or getting health screenings for early detection. You could sort of play out the same access issues for any one of those that might look a little different, but it's going to have a lot of similarities across those.
Right. So the title of your course is Evidence-Based Public Health. Can you give some examples of, like, what is evidence? When you think about it, it's like almost vague. So what is evidence? What are some types of evidence? And then we'll talk from there. Yeah,
I always say, so for a scientist, evidence is going to be some kind of a peer-reviewed study that ends up in a journal or a book or some other sort of scientific venue. That's a small slice of the world. And like part of the world I live in with researchers, they do really well communicating about evidence to other researchers, but not so well to everyone else. Then if you get sort of a public health practice audience, it would be things like we talked about surveillance or program evaluation data or interviewing people who are affected by a condition in a community to find out what the barriers are for their prevention or their care. And then you can get to more of the general public. I think if you say the word evidence to sort of your average public, it might be more from the justice system or from crime, like the shows that are on now, the CSI and the Laws and Orders of the world, where you've got sort of evidence of a crime or evidence that would be used in a courtroom setting. And some of that evidence is people's experience or word of mouth. But even in health, there's some really important decisions we make about health that are word of mouth. Like think about if you move to a new community and you've got young kids and you're trying to find a pediatrician. How do we do that? We don't go to some scientific summary. We usually talk to our colleagues and say, do you know a good pediatrician? Usually the people where you work, because that's where most people get their health insurance. And then you try that person out. Well, that's not very scientific, but it seems to work for most people. So evidence is truly in the eye of the beholder. We need to think about who the audience is for the messaging we're doing. And if that's your mother or grandmother or a colleague or a researcher or a policymaker, and talk in the way that evidence makes sense for that audience. And I think that's partly both for researchers and public health practitioners. We don't always do a great job.
So what I'm hearing is that evidence can be both qualitative and quantitative.
Yeah. And it can be scientific and it can be experiential or people's lived experience. And it can be anecdotal. I mean, that might, if you think about, well, California is setting up a strategic plan for the next 20 years for public health. Well, you probably don't want to base that on anecdotal evidence, but it's still a form of evidence. And people's, collective anecdotes are lived experience. And so that's also important to keep in mind. And it's really important, as what you said, it's both quantitative, the numbers, but it's also qualitative, the words. And both are important, and we shouldn't only value one or the other.
That reminds me of a conversation that I had with Lumi Malombo. She runs an organization called JB Dondolo, and she works in Zimbabwe, and she is focusing on clean water implementation there. Now, she was talking about in the very beginning of her work in Zimbabwe, she thought that the people needed a health clinic. So she started working on a health clinic. And then the people there were like, what are you doing? We don't want this. We want clean water, Mm-hmm. And so that's evidence in itself. So that makes a lot of sense. So what makes evidence strong or weak? Hey there, I hope you're enjoying this episode. And if you are, would you do me a tiny favor? Show me some love by doing one or more of these three things. A, click the support this podcast link in the description to donate a few dollars toward the production of this podcast. My dream is to do this full time, and your support would mean the world. B, you can write me a review on Apple Podcasts and or rate me on Spotify to give me a boost in the algorithm. Or C, share this episode with someone who would love it just as much as you do. I truly and deeply appreciate you. Let's get back to the episode.
Well, there are formal principles that you could follow. So when you look at a certain body of literature, for example, how the evidence has been decided upon. So that contains things like study or evaluation design, or how a study or an evaluation is carried out. And there's a whole range of formal rating systems for those. And the strength of evidence, I always think like the strength of evidence depends on the kind of question you're trying to answer. Like if you're studying the effectiveness of different types of drugs, usually they'll do that through a randomized trial where people get randomized to drug A or drug B or placebo. And the randomization is a way to, it's in a way sort of leveling out the differences between people that you might not always be measured, but it lets you kind of level things out and know that whatever you find for effectiveness of drug is attributable to the drug, not to some other random thing going on in a population. Well, then think about studying something like policy change. Like think about, let's say that a state like Massachusetts passes a huge increase in their tobacco tax. You'd study that, but you can't randomize anything to study that. You're going to just study how smoking rates go up or down based on a policy change. And so what I would say is the evidence you want to do, the strength of the evidence needs to just be related to the kind of evaluation question you're asking. And that's what we try to teach in all of our trainings around that. And then sort of the strength of the evidence is also, if you're trying to reach a certain audience, who's delivering the messages about that evidence. So if you're talking to a policymaker, you might want, like an elected policymaker, be best to have someone from their district come and talk to them about it, not some scientific researcher nerd from the university, right? And so and we call that sort of the message deliverer, or sometimes we call it the opinion leader. It's really important that not only what the message is, but who's delivering it.
That is it's so true. It's like, who are you? You don't live here. It's almost like when politicians run for like mayor or whatever, run for office in a completely different state. And you're like, why?
Yeah, I know. They're just going where they can win.
So how can we begin to incorporate some of these strategies as public health workers today?
There's probably a whole bunch of different things we could do. One would be have public health be more visible and message better. Some of the things I was talking about selling prevention a little more equally as we sell disease treatment, and figuring out ways to communicate more effectively, I think, is really important. a lot of what we talked about had to do with training, capacity building. So making sure that we do everything we can to have the most highly trained public health workforce, both in the United States and globally, that we possibly can, and invest in some of these sort of training and capacity building programs that we know work, but don't always get invested in because resources have to be spent somewhere. There are a lot of really great resources out there that we rely on in our trainings. A lot are with the CDC in Atlanta. A lot are with groups. There's one I really like called What Works for Health that is an initiative funded by the Robert Wood Johnson Foundation. And then I think a lot of the work, probably the last 5 to 8 years, has been around centering health equity in everything we do more, and not making sort of health equity an afterthought where you measure something and say, well, did this population get healthier or not, but making it the centerpiece for a lot of the things we do. I think that is also really important. And then fundamentally, at the bottom line of this, the biggest impact on people's health is policy. And elected policy only gets put in place that's supporting public health if we elect people who are going to do that. And so I think voting is a public health issue, equal access to voting is a public health issue, and electing people, like I always tell the students in my class, which, tend to be 20 somethings, people in the youngest age group vote at a dramatically lower rate. Like people in their 20s compared to people in their 60s and 70s vote at a dramatically different rate than in those groups. Younger people vote a lot less often, in some elections even half as likely. And so if people voted, like if young people voted the same as people in their 60s and 70s, we would have a very different looking set of elected officials. And so I think voting is a public health issue, and public health is driven by the elected officials and the policies they implement. And I think that hasn't always been seen as something that's central, as something that we could incorporate more in what we're trying to do. And then I sort of circle back to funding and resources, is put our money where our mouth is. That if we think prevention is important and we want to have healthier communities, we need to invest more in prevention, not the kind of measly 5% that we invest now out of our total health budget.
So what are we spending most of our money on?
Disease treatment, the kinds of things that happen in the last 6 months or a year of life, expensive medical treatments, expensive surgeries, transplantations, expensive cancer treatments. Most of the money will be spent on chronic disease treatment, which, the biggies are obviously heart disease, stroke, cancer, diabetes. And it's different in different parts of the world. In lower and middle income countries, infectious disease will have a larger burden than the chronic diseases here are. But we invest a large proportion of our total health dollars in the last 6 months of life. And we underinvest in youth, and we underinvest in maternal health, and we underinvest in general in prevention. And so, shifting that is not a simple thing, but it's definitely one worth fighting for and working on.
What do you think the first steps are to shift?
Probably starting with policy, probably getting officials elected in elected bodies, local, state, national, international, who will represent the promotion of public health and center the promotion of public health.
Right. This has been really, really interesting. I would say this is like a 30-minute crash course.
Yeah, it sort of is.
Ross, thank you so much. Do you have anything else that you'd like to share with our audience?
It's been really great talking with you. You had some great questions. And anything we can do to put public health in the front of people's thinkings and have people understand public health more and the good that public health does is all for the better. So thank you for bringing this topic up and having this conversation.
Thank you for listening to this episode. If you'd like to learn more about today's topic and guest, head over to the show notes linked in the description of this episode. There, you can get access to resources, links, and ways you can get involved in the pursuit for global health. And if you loved this episode, don't forget to write me a review on Apple Podcasts and rate the podcast on Spotify. It helps me get in front of more people just like you and continues to elevate the causes we are so passionate about. I'll see you in the next one.